Welcome to this explainer. Look, today we're jumping into something absolutely crucial for everyday practice, a definitive clinical guide for safe pupil dilation. We are basing our analysis heavily on the expert lectures and guidelines authored by Dr. Dirk J. Boyesen. He lays out some incredibly structured, no-nonsense protocols for navigating the very real risks associated with routine pupil dilation. So, if you want to confidently assess anterior chamber angles, you are definitely in the right place.
Okay, let's set the stakes right out of the gate. 0.64%. That's the percentage of adults over the age of 60 who have anatomically narrow anterior chamber angles. Now, I know that might sound like a tiny fraction, but in a busy clinic, that means you're going to regularly encounter patients whose angles could dangerously occlude the second you use Medratics. It's basically a game of clinical roulette if you aren't checking carefully.
To navigate this challenge, we've got a quick roadmap for today. 1. The dilation danger. 2. Identifying angle landmarks. 3. The Schaffer grading system. And finally, 4. The 2+ rule for dilation.
All right, part 1. The dilation danger, risking angle closure glaucoma.
You know, the specific mechanism of danger here is actually pretty fascinating and a little counterintuitive. The sources point out that while your ultimate goal during an exam is a maximally dilated pupil, it's actually the minimally or mid-dilated state that is the real danger zone for pupillary block glaucoma in narrow angles. If you miss a dangerously narrow angle, you can literally induce irreversible blindness from angle closure glaucoma. You simply have to assess the angle first. There's just no getting around it.
Moving right along to Section 2, identifying angle landmarks, basically mapping the anatomy. When we're sweeping from anterior to posterior, the big players you've got to nail down are Schwalbe's line, the trabecular meshwork, both the pigmented and non-pigmented parts, the scleral spur, and finally the ciliary body band. Getting totally comfortable identifying every single one of these structures is your absolute first line of defense.
Let's break these down, starting up front with Schwalbe's line. Clinically, this is described as a translucent collagen condensation of Descemet's membrane, sitting exactly between the trabecular meshwork and the corneal endothelium. But here is where you have to be super careful. Sometimes it's heavily pigmented. If a patient's iris is convex, a pigmented Schwalbe's line can easily trick you into thinking you're looking at the trabecular meshwork, so precision is key here.
Now, moving posteriorly past the trabecular meshwork, boom, we hit the scleral spur. This shows up as a white internal projection of the angle wall. It's actually where the longitudinal fibers of the ciliary muscle attach, and it beautifully contrasts with the grayish color of a non-pigmented meshwork, which makes it a highly reliable, bright white landmark if you know what you're looking for. To lock all of this into memory, the sources give us a fantastic little mnemonic going from posterior to anterior. I can't see this stuff. Iris, ciliary body band, scleral spur, trabecular meshwork, and Schwab's line. So the pro tip here is if you ever find yourself lost or disoriented while looking into the angle, just recite "I can't see this stuff" to mentally walk yourself from back to front.
Okay, on to Section 3, the Schaffer grading system, where we assess the angle width.
So historically, this has been a bit of a mess in the literature, right? It is absolutely crucial to differentiate the dominant Schaffer system from the older Shaya system because they literally take the exact opposite approach. Under the Schaffer system, a wide open angle is a 4. Under the Shaya system, a wide open angle is a 0. For our modern clinical guides, including Dr. Boyesen's protocols, we strictly use the Schaffer grading scheme.
With the Schaffer scale, we're grading from 4 down to 0. A grade 4 is 35 to 45 degrees, wide open, totally incapable of closure. But circle grade 2 in your mind. A grade 2 is an angle of 10 to 20 degrees. The clinical implication here is huge. This is a narrow angle that is highly capable of closure. And grade 1, which is 10 degrees or less, that is dangerously narrow.
You can actually visualize how this geometric angle squishes down from a wide open 45 degrees all the way to a partially or totally closed state. That 20-degree mark is where the alarm bells should be ringing, and as the sources remind us, the space bounded by the iris, ciliary body, and the wall isn't really a true angle in a strict geometric sense, but grading its angular width is exactly how we determine a patient's susceptibility to closure.
And here's how this links right up with your preliminary slit lamp exam. A Schaffer angle of 20 degrees or less directly correlates with a Van Herk estimation of 1/4 to 1 or less.
Basically, if your initial slit lamp check using the Van Herrick method shows an anterior chamber depth of less than 1/4 the corneal thickness, gonioscopy isn't optional, it is strictly required before you even think about touching a dilating drop.
Which brings us to part 4, the 2+ rule for dilation, the safe clinical application.
Before you instill a mydriatic, your gonioscopic evaluation absolutely must confirm at least a 2+ angle across the entire 360 degrees. So what does a 2+ angle actually mean in practice? It means you must see 100% of the trabecular meshwork in all 4 quadrants. If you do not see the meshwork all 360 degrees around, you stop right there. And this right here is the ultimate takeaway of our explainer today, straight from Dr. Dirk J. Buson's clinical guidelines. The golden rule is never dilate if fewer than 2 structures are visible in all quadrants. That is the 2+ rule in a nutshell. Schwabe's line is structure 1. The trabecular meshwork is structure 2. If you can't see both of those in every single quadrant, you do not dilate. It's a simple, non-negotiable threshold for patient safety.
By leaning on that "I can't see this stuff" mnemonic and strictly enforcing the 2+ rule, you can confidently protect your patients from pupillary block glaucoma. You've got the structural map and you've got the clinical threshold. So, my question to you is, are you ready to safely evaluate your next patient's angles? Think about how you'll implement this strict, structured assessment in your very next exam as you head back into the clinic.